Okay, greetings. This is going to be a lecture involving integration of the various endocrine hormones as they relate to energy and select electrolyte balances. So we're going to get started. Now, neuroendocrine regulation of energy storage, mobilization, utilization, there's going to be several different phases we're talking here. One is basically while you're eating. The other is when you're not eating. That seems kind of obvious, but the two phases are regulated to ingestion of a meal, which alters the day in regulation of energy metabolism. Another way to say that is basically look at what happens when you have fed, what changes occur there, what happens after you're fed, and you're going through your day-to-day events, and what changes occur there. So first off, we're going to talk about the fed state or fed phase. This reflects a state in which energy is stored in the form of energy-rich compounds, particularly ATP, phosphocreatine, glycogen, fat, and proteins. Now, we have to keep in mind that we have what is called an anabolic metabolism. This part of the metabolism is where biomolecules are combined into more complex molecules. Basically, we're going to store the nutrients. Now, in the fasted or catabolic phase, this is the period during which endogenous energy sources are utilized. In other words, we're going to start using that which we stored. Now, as we continue through this, we're going to be talking first about the fed state, and we have to come up with glucose, of course. That's tightly controlled by glucagon and insulin. Following insulin, that is after a meal, glucose uptake is increased in fat, muscle, and in the hepatosplenetic bed. Now, basically what we're talking about is we pull all of this together. Some of it will go off into the circulatory system, into the hepatic portal system. And so as a result, the liver is not going to have an output of glucose. That's being suppressed. What is going on in the liver is formation of glycogen. And so we're going to have more glycogen synthesis to store that glucose. Now for fat, during this caloric excess or abundance, fat is going to be stored in the form of triacetylglycerol in adipocytes, fat cells. The principal hormone, though, is going to be insulin. Now, this is going to oppose hormones. Opposing hormones are growth hormone, GH, and leptin, which will inhibit lipogenesis. You want to also note that the balance between lipogenesis and lipolysis is followed by fatty acid oxidation, and that is determining the total accumulation of body fat. So what am I saying? Lipogenesis is the making of fat. Lipolysis and then oxidation of these fatty acids that are freed up. Really, this balance determines whether or not we have an accumulation of body fat. Now, what about protein? Whole body protein pools and the individual tissue pools are determined by the balance between protein synthesis and degradation. Hormonal regulation is predominantly by insulin, growth hormone, insulin-like growth factor, IGF-1. During the fed phase, insulin inhibits proteolysis. Growth hormone stimulates protein synthesis, and IGF has anti-proteolytic effects. Normal growth and development are controlled by growth hormone and testosterone. Now, thyroid hormones are required for normal growth and development as well, but they will also stimulate bone growth by increasing the secretion of growth hormone and IGF-1. As you can see in this chart here, which is from your text, here you have basically the breakdown of fat, protein, and carbohydrates. Basically, how does this relate to health and disease? Well, if we have excess fat storage, you're facing the possibility of metabolic syndrome, insulin resistance, and an increase in cardiovascular disease. If you have an excess of proteolysis, you have a loss of lean body mass and increased risk of disease, morbidity, and mortality. If you have, shall we say, diseases of glycogen storage or degradation in the liver, that you could be ending up with hypoglycemia in the muscle weakness. So as you can see here, when we talk about on this side of the coin, the lipogenesis, the protein synthesis, and the glycogen synthesis, what we're talking about on this side is the fed site, the site that you've been taking in nutrients, etc. And all of these hormones here, insulin, IGF-1, etc., are helping to let this occur. When we talk about the breakdown of lipids, lipolysis, breakdown of proteins, proteolysis, and the breakdown of glycogen, this is where we are in the post-fed state, and you can see the hormones that are involved here. Now, this is where we talk sometimes about the fasted state, but it doesn't mean that you're fasting for weeks and days and days and days. This is talking about the period where you're not putting anything, you're not consuming any food. Catabolism of stored energy sources provides energy required for bodily functions. Now, there is a term called basal metabolic rate, BMR. Think of it this way. This is the amount of energy required for basic brain function, breathing, enzymatic activity, and other functions without any physical movement of the individual. Think about it from the perspective that you're not doing anything. It's almost as if, well, I'm asleep. Well, when you're asleep, what happens? Your kidneys are still functioning. They're still filtering. Your heart is still beating. You are having muscular activity for breathing, and you are having basic metabolic activity in the brain and electrical exchange. BMR is like that. There's no real movement. There's no real exercise going on. Now, during the fasted state, glucose, here we're talking about hepatic glucose production, this is going to be increased. Peripheral glucose utilization is inhibited. Glycogenolysis provides 50% of the liver glucose output. Now, blood homeostasis in this state is the result of hormonal regulation of glycogenolysis, gluconeogenesis, and glucose uptake. Now, when we talk about fat during this fasting state, overnight fast, for example, your BMR energy is provided by fatty acid oxidation. This is derived from adipose tissue. Epinephrine stimulates lipolysis, and insulin inhibits lipolysis. Now, lipolysis mobilizes triglycerides, providing fatty acids as energy substrates for heart, liver, and muscle, as well as substrates for glucose. That's in the form of glycerol. And you also have lipoprotein, the free fatty acid from free fatty acids, and that's where you're going to have lipoprotein synthesis to the liver. The release of glycerol and free fatty acids, yes, that's what the FFA means, is inhibited by insulin but stimulated by catecholamines. During fasting, plasma insulin decreases and growth hormone and glucagon levels increase. Now, you got to keep in mind one of the very, very important points. The brain cannot use free fatty acids for energy. So when glucose levels decline, the brain has to have some energy source or you basically will pass out. That's where you get ketone bodies. They're going to provide alternative energy source for the brain. Where do ketone bodies come from? Free fatty acids that are broken up. Okay? Now, in the protein area, under catabolic conditions, essential proteins are going to be degraded. What I mean by that is you're going to basically break them down into amino acids. Now, glucagon, cortisol, and epinephrine together favor muscle protein breakdown and uptake of hepatic amino acids. Effects of glucagon are mostly through increased hepatic amino acid uptake. Epinephrine increases the production of gluconeogenic amino acid alanine, and by the muscle, and its uptake by the splanchnic bed. Now, what about counter-regulatory hormone effects? Okay. Glucagon, this is the hormone that primarily stimulates hepatic glycogenolysis and gluconeogenesis. What's the overall? Overall, you're going to have this increase in hepatic glucose output. Growth hormone and cortisol, both of them will facilitate glucose production and limit glucose utilization, but neither plays important roles in countering hypoglycemic episodes. All right. Now, what does that mean? Well, if you have those hypoglycemic episodes, that's where you have the individuals, sometimes they have to have that hard candy or that glucose gel if they're having a hypoglycemic effect and they are diabetic, such as diabetes 1. Now, cortisol will contribute to glucose regulation by permissive effects to lipolytic action of growth hormone and catecholamines in adipose tissue and in glycogenolysis of catecholamines in skeletal muscle. Epinephrine. This will stimulate hepatic glycogenolysis and hepatic and renal gluconeogenesis. By the way, as the book mentions, you get something from the renal, basically the kidneys, but it doesn't do an incredibly large amount as compared to, let's say, the liver when it comes to making new glucose from other sources like amino acids and things like that. Now, basically, this process is going to be largely done by using lactate, alanine, glutamine, and glycerol as precursors. Epinephrine helps to increase hepatic glucose output. And with glucagon, this is going to act very, very quickly. We're talking minutes to boost plasma glucose levels. And as you can see from this chart, this is very, what they call information dense, but it's going to take a second. Remember that you have insulin as one of the major players here, glucagon and the major players here. The liver islet axis, when it's talking about islets of Langerhans that release the insulin and the glucagon, you're going to have these properties. If you notice here where it has a blunt area, it's inhibiting. If it's an arrow, it's allowing it to occur. Okay? So, what does that mean for glucagon? It's going to be able to encourage in the liver gluconeogenesis, glycogenolysis. Insulin will try to inhibit these. And you can see the glycogenesis and the glycolysis occurring also over here. You also get a really nice representation of some of the other neurotransmitters, some of the endocrine secretions. And the gut islet is also, gut islet axis is also important here. Remember, you're going to have GLP-1, CCK. We're going to talk a little bit more about gastrin, more or less, perhaps next week. But these are some things that just take some time to review. Now, let's talk about the neuroendocrine regulation of energy metabolism during extreme conditions. Okay, we're going to take first something like starvation. And then we're going to go to the other side. What if we had exercise? And all of this is to counter hypoglycemia. So the key issue for tight regulation of glucose levels is to avoid insulin-induced hypoglycemia. Keep in mind that the normal blood glucose levels are 70 to 110 milligrams per deciliter. Upon a decrease below the normal glucose levels, you're going to start having counter-regulatory neuroendocrine responses. These are going to be triggered, and they're going to include sympathetic activation, particularly epinephrine release. So let's talk about epinephrine. Epinephrine will increase the suppression of pancreatic insulin release, stimulate glucagon release to increase hepatic glucose release. So there's one area where you're going to start bolstering up the levels of glucose in the plasma. Growth hormone and cortisol will release. They will also contribute to this increase in hepatic glucose output and suppression of tissue glucose uptake. Now, you're also going to get afferent signals, basically information, sensory information going back to the brain of the glucose levels. They're transmitted to the hypothalamus and to several other sections of the brain, the nucleus solitarius, which is in the medulla, and this is all coming from the vagus nerve. The response is sent via the hypothalamus for inhibition of hepatic and adrenal nerve activity, resulting in the decrease in release of the adrenomedullary catecholamines. It will also be removing inhibition of pancreatic insulin release and allowing hyperglycemia to induce insulin release. What we said a minute ago was that there was tight regulation. So if you go too low, you're going to start bringing up the glucose levels. But once you go over that 110 mark, you're going to also get the next part of the phase where you're going to have to bring the levels down to that safe zone. And that's when you're going to have removal of the inhibition of pancreatic insulin release. Okay? Here we have this gentleman, too much insulin, too much glucagon. Okay, too much insulin, you could get hypoglycemia. That's low blood sugar, and you can see all of the effects here. Too much glucagon, and you could get hyperglycemia. That is high blood sugar. Now, what about, let's continue on extreme conditions here, the regulation of energy metabolism during exercise. The neuroendocrine response is targeted to increase the energy demands of exercising muscles. To a point, this is part of fight or flight. So we have the sympathetic nervous system that's going to be activated. But along that, you're also going to have the release of growth hormone. You're going to have the activation of the HPA with subsequent release of catecholamines and cortisol, suppression of insulin, and stimulation of glucagon release. Once glucose is inside the skeletal muscle, it's sequestered there by oxidation via the glycolysis that occurs. Or if you have an abundance or you're going anaerobic, you're going to get it released as lactate. Now, lactate is no problem. It's going to go back into the blood. It's going to get to the liver. It's going to be converted by the liver back into glucose. This is your gluconeogenesis. And this is via the Cori cycle. Okay. As the exercise increases, the skeletal muscle will switch from lipid to carbohydrate energy substrates. And you can see some of this in this chart, which is a very nice one that's in your text. And you can see how you have it. FFAs are always free fatty acids. You're going to be seeing an increase in lipolysis. It's going to help when you are going through situations of exercise, etc. You will also see the neural inputs here for the release of cortisol, as well as epinephrine, norepinephrine. Okay? So this should help you as you review these different aspects. Keep in mind protein, glycogen, and fat are really going to be broken down to amino acids, glucose, and glycerol, and fatty acids. Let's talk about the maintenance of long-term energy balance and fat storage. The disruptions of energy intake, in other words, too much or too little, are discussed here. The catabolic state, in states of starvation or under conditions of increased energy substrate demands, the effects of cortisol, epinephrine, and glucagon favor overall catabolic effects. Insulin effects are going to be blocked. The metabolic responses that predominate are going to be those of catabolism of stored energy. So in other words, glycogenolysis, breaking down glycogen to glucoses. Lipolysis, breaking triglycerides into free fatty acids, glycerol. The breakdown of lean muscle. This is muscle proteolysis. Now what we're talking about here is taking the muscle, breaking it down into individual amino acids. This is, of course, going to result in the loss of body mass. One thing you want to note here, under these conditions, production of growth hormone, IGF-1, and binding proteins becomes dysregulated. And this is going to contribute to the overall catabolism. So what you have is you're trying to shift everything to mobilize all the energy resources available to manage the body to produce glucose or some energy source. So anything else that might inhibit that gets shut down. Let's talk about obesity. This is defined as a significant increase above ideal weight, the weight that maximizes life expectancy. Now, BMI is known as the body mass index. It's an indicator of the adiposity or fatness that accompanies obesity. Life expectancy is reduced when the body mass index is significantly increased above the ideal level. Obesity is associated with increased risk of diabetes, dyslipidemia, hypertension, heart disease, diabetes, and cancer. You want to keep in mind the responsiveness to hormones that regulate lipolysis varies according to the distribution of fat deposits. For example, lipolytic response to norepinephrine is greater in an abdominal rather than in the gluteal or femoral adipose tissue in men and women. The release of free fatty acids from abdominal adipocytes directly into the portal system, increased hepatogluconeogenesis and hepatic glucose release, and hyperinsulinemia are key markers for patients with upper body obesity. Here's the classes, and part of this has also been taken from your book, and you can look at this. If you'll notice here, you have the classifications: underweight, normal weight, overweight, pre-obese, and then obese class 1, 2, 3. It's interesting to note kilograms per square meters, but here's the more important one. Risk of comorbidities, basically the risk of illnesses. If you're low, that's usually kind of good, but you face a risk of other clinical problems will be increased. If you're normal, you're going to have an average risk of illnesses. And what you start seeing as you move from overweight to obese to class 1, 2, 3, that you are going to greatly increase the risk of these illnesses. Then we bring us up to the metabolic syndrome, Syndrome X. Now, this is a metabolic syndrome that refers to the co-occurrence of several known cardiovascular risk factors, including insulin resistance, obesity, atherogenic dyslipidemia, and hypertension. These conditions are interrelated and share underlying mediators, mechanisms, and pathways. The metabolic syndrome ties together insulin resistance, visceral adiposity, dyslipidemia, and hypertension. These have been known in the past to be interrelated. If you take a look at this slide, which I thought was very important, to qualify or to be categorized with metabolic syndrome, it's defined as having at least 3 of the 5 components: an elevated waist circumference, an elevated triglycerides of over 150 milligrams per deciliter, or drug treatment for elevated triglycerides, low HDL cholesterol below 40 for men and below 50 for women, or drug treatment for low HDL, elevated blood pressure, systolic is 130, diastolic over 85, or hypertensive drug treatment, elevated fasting glucose, well over 100 milligrams per deciliter, or drug treatment for elevated glucose. So any 3 of those 5 qualifies an individual for having metabolic syndrome. There are a couple of terms I thought I'd get into just a little bit more because they do have some endocrine components. The key features of atherogenic dyslipidemia are a high plasma triglycerol levels, a low HDL cholesterol levels, and an increase in the small, dense LDLs, insulin resistance, and visceral obesity. These are all associated with atherogenic dyslipidemia. Now, insulin resistance leads to atherogenic dyslipidemia in several ways. First, insulin normally suppresses lipolysis in adipocytes. So impaired insulin signaling increases lipolysis, resulting in increased free fatty acid levels. In the liver, free fatty acids will serve as a substrate for synthesis of triglycerides. Now, free fatty acids also stabilize the production of ApoB, which is really a major lipoprotein of very low density lipoproteins, VLDL particles. And this is going to result in more VLDL production. Okay? Now, the second major situation here is that insulin normally degrades ApoB through a PI3K dependent pathways. So insulin resistance directly increases VLDL production. Third, insulin regulates the activity of lipoprotein lipase, and this is the rate limiting and major mediator of VLDL clearance. Hypertriglycemia in insulin resistance is the result of both an increase in VLDL production and a decrease in VLDL clearance. All right. Now, the endothelial dysfunction, broadly defined, occurs when the endothelium fails to serve its normal physiological and protective mechanisms. This is another aspect I wanted you to be aware of. This may occur when normal responses of the endothelium are affected, for example, by oxidative stress, hyperglycemia, advanced glycolation products. In other words, when you have sugars that attach the A1C situation for hemoglobin, when you have also elevations in FFA, inflammatory cytokines, or adipokines. As you can see here, here's metabolic syndrome. And we have overnutrition, physical inactivity as the environmental factor. This is going to lead to a visceral fat accumulation. You might also have genetic factors, such as the small nucleotide polymorphisms, particularly of this one here. This is going to lead to a reduction of adiponectin, okay? The reduction of this can lead to blood hypertension, which is the elevation of blood pressure, which can lead to atherosclerosis. Decreases in adiponectin can also result in dyslipidemia, which means you're going to have an elevation of triacetylglycerol, and a decrease in the HDL cholesterol. Again, concluding with atherosclerosis. Of course, adiponectin can directly affect the onset of atherosclerosis. It will also play a role in insulin resistance, type 2 diabetes mellitus, and again, atherosclerosis. Now, we're going to talk about the regulation of energy intake. We've been talking about this in an oblique way, but now we're going to talk directly of what hormones play a role. The hormones that regulate the central release of peptides, that regulate appetite and satiety, we're going to talk about. You want to note that insulin and leptin modulate the hypothalamic neuropeptides and regulate feeding and body weight. So what is leptin? Now we're going to get, this is just a little picture of this. I've got more of it coming soon, but leptin's a peptide hormone. It's produced in adipose tissue, of all things, and reflects body fat mass. Now, the hypothalamic integration, this is where the hypothalamus will receive input from the nucleus tractus solitarius, the area postrema in the brainstem. These sites relay neural and hormonal signals from the GI tract. So let's talk about a GI hormone, cholecystokinin, CCK. This is a peptide hormone. It is associated with satiety, the sense that I'm full. Don't need any more food. It's produced from the duodenum. Ghrelin is a peptide hormone produced from the endocrine cells of the stomach. Circulating levels decline during meals and are highest in the fasting state. It is a potent growth hormone secretagogue, meaning helping us for the secretion of growth hormone, and it is also an appetite stimulant. Now, you also have several other ones that I wanted to bring up. Glucagon-like peptide 1. We've already talked about GLP-1 before. It is a peptide hormone. It's secreted by endocrine cells. Basically, these are going to be cells in the small intestine, and it suppresses appetite. Adiponectin is a peptide hormone. We're going to go a little bit more into that later. Neuropeptide Y is a peptide neurotransmitter, has what they call orexigenic peptides that are found in the brain. Basically, it encourages food intake. And it's interesting that neuropeptide Y stimulates food intake with a preferential effect on carbohydrate intake. It decreases latency to eat and increases motivation to eat and delays satiety by augmenting the meal size. If you want to get more into the various types of components, neurotransmitters, as well as endocrine hormones, you can go over to the text, page 266, table 10.3. Let's talk a little bit more about leptin. As I said, it's a peptide hormone secreted by adipose tissue. It has specific effects on fat metabolism. It will decrease in its levels in fat storage. It will increase in sympathetic mediated energy expenditure. It will increase in expression of uncoupling proteins. This is what this hormone is doing. It will decrease in triglyceride content by increasing fatty acid oxidation. It will also decrease activity and expression of esterification and lipogenic enzymes. And finally, leptin will decrease the lipogenic activity of insulin, favoring lipolysis. And you can see all this in this diagram here. Here's leptin, produced from the adipose tissue, acting on both the brain and a variety of other areas of the body, but particularly the brain. You will also see this in several other good diagrams, which I wanted to include. It regulates appetite. It will lead to activation of immune cells. It can lead to higher blood pressure, helps regulate the synthesis of thyroid hormones, decreases glucose-stimulated insulin secretion, increases the heart rate, regulates bone mass, and regulates the menstrual cycle. Here we have leptin, where it increases the energy expenditure but decreases the appetite. It will also decrease bioavailability of nitric oxide, which plays a role in blood vessel regulation. And also we have hypertrophic effects, free fatty acid uptake, oxidation. We will see ECM production and cardiomyocyte apoptosis is decreased. It will also play a role in the inflammatory cells activation. Now, here we have adiponectin. Now, by the way, the adipo with a Q, that's really just the name for the gene that makes adiponectin. This is a protein hormone and an adipokine. Okay, so it's being released from adipose tissue. And it is involved in regulating glucose levels as well as fatty acid breakdown. It is produced primarily in adipose tissue, but also in muscle and even in the brain. The hormone appears to play a crucial role in protecting against insulin resistance and diabetes, as well as atherosclerosis. It has been noted that decreased adiponectin levels are thought to play a central role in the development of type 2 diabetes, obesity, and cardiovascular disease in humans. Adiponectin will increase insulin sensitivity and tissue fat oxidation. It will also result in reduced circulating fatty acid levels and reduced intramyocellular and liver triglyceride content. It is interesting to note that levels are decreased of leptin in obese patients. Plasma levels, interestingly enough, correlate negatively with triglycerides. So in other words, the greater the amount of triglycerides, the lesser the amount of leptin, and vice versa. Or excuse me, of adiponectin, I should say. Now, here is adipose tissue. Here's adiponectin being released, and it acts on the brain, on the kidney. It inhibits inflammation. It has a cardioprotective effect, as well as protective effect for the blood vessels. It plays a role on lipid and glucagon secretion for the liver, lipid and glucose metabolic regulation, increases glucose uptake in muscles. You can see this also here. The interesting thing just to mention, by the way, as we're looking over this is, it has a protective capability for coronary artery disease, type 2 diabetes, insulin resistance, because if you notice here, one of the interesting things that adiponectin does is it decreases inflammation in the formation of what they call foam cell formation. Those are the cells that help play a role in development of arterial plaques. And here is another endocrine setup here, which they really take and look at which hormones play which roles in the area of the hypothalamus. But since this is not a neuroscience area, I'm not going to go heavy into this. I do want you to be aware that there is some interplay between many of these hormones and the hypothalamus, and then how you have variations in things like glucose and lipid metabolism, food intake, thermogenesis, glucose balance, lipid oxidation, etc. Now we move into another area of regulation, and that is electrolyte balance. First, we're going to talk about the regulation of sodium balance, and then we're going to move into several others. The primary electrolyte, sodium, regulates extracellular fluid levels, ECF levels, and osmolarity. It is essential for maintaining hydration, water balance, osmotic equilibrium, plasma volume, acid-base balance, and preserving nerve impulses and muscle contractions. Now, sodium is maintained in the ECF by sodium-potassium ATPase. That's the basically sodium-potassium pump. Water crosses the membranes via these channels called aquaporins. Overall, the mass of sodium is really under aldosterone regulation, whereas sodium concentration in plasma is under ADH regulation. When we talk about intake, distribution, and secretion of sodium secretions average about 140 millimolar per liter in the plasma, and yet you have 10 millimolar per liter intracellularly. So there's a vast difference. And by the way, when you say plasma, you're basically saying the same amount for extracellular fluid. Okay? Intracellular fluid is very, very different. Now, sodium intake is usually through food. Some data suggests that there is actually possibly a hypothalamic area involved in salt appetite, but this is not completely understood. The sodium balance is maintained by hormonal regulation of renal sodium excretion. Most sodium reabsorption occurs in the loop of Henle prior to the distal tubule. And here we have the collecting tubule, we have the glomerulus, we have the proximal convoluted tubule, then we have the loop, thick and thin, the loop of Henle, and then we have the proximal convoluted tubule, excuse me, not the proximal, this is the proximal, we have the distal convoluted tubule, and they mention some areas of drugs that play a role, but the more key importance here are the hormones that play a role and what they do with reabsorption of various Electrolytes, particularly right now we're focusing on sodium. Later on we will mention a little bit about magnesium, calcium, and we're going to talk a little bit about potassium and phosphate. Now, what is the hormonal regulation of sodium and water balance? Antidiuretic hormone, ADH, is also known as vasopressin. And so the book sometimes will use AVP, arginine vasopressin. This hormone controls water excretion. ADH stimulates insertion of aquaporins into the cell membrane, increases water reabsorption in the collecting ducts, and concentrates excreted urine. Angiotensin II elevates blood pressure by direct vasoconstriction, potentiation of sympathetic nervous system activity, stimulation of aldosterone synthesis, increase of sodium reabsorption, stimulation of ADH release, increased water retention, and the intrarenal afferent and efferent arterial constriction. So here's the idea. If you have an increase in the constriction, vasoconstriction of both afferent and efferent, you're going to basically increase the pressure that's going to occur in the glomerulus to increase the filtration. So it's like angiotensin II does it all. Well, not really. But it is a major part of the RAAS system that we've talked about before. Another component, aldosterone. This increases sodium reabsorption and potassium excretion in the distal tubule and collecting duct of the nephron. It manages long-term blood pressure regulation. Keep in mind that aldosterone is under the positive regulation of angiotensin II, which you just mentioned. Now, there is another interesting hormone, but it does the absolute opposite. It's called atrial natriuretic factor, ANP. Now, it's a peptide hormone synthesized in the cardiac atrial cells. By the way, they also make it in the ventricular muscle cells. But it's released in response to the atrial stretch via mechanosensitive ion channels. The release of this hormone is triggered by volume expansion. The greater amount of fluid, the greater amount of stretch as the heart is contracting and filling up with the volume of blood. So obviously you're going to have this release. Now the effects are very different. They increase glomerular filtration. They decrease proximal tubule sodium reabsorption. This is going to result in increased natriuresis. In other words, increased sodium excretion in the urine. There are some additional effects that include inhibition of renin, aldosterone, ADH release, and vasodilation. So what this is doing is sort of the counterbalance to the RAAS system. Now, there are abnormalities in sodium and water balance. They're defined in 4 categories. Excessive sodium, characterized by expansion of ECF volume and low effective blood volume. This can happen with heart failure, hypoalbuminemia, and renal insufficiency. What you're looking at is what we would call at times edema, in tissue. Deficit in sodium is characterized by reduced ECF volume. Excess water caused by excessive intake or enhanced ADH release. This is going to be manifested by hyponatremia and hypoosmolarity. In other words, there's more water. It is going to dilute down the amount of electrolytes. And it's going to be, in essence, diluting down the concentration of solutes, which accounts for the hypoosmolarity. As the numbers of sodium are being overwhelmed by the greater numbers of water molecules, that's where you're going to have hyponatremia. Finally, we have water deficit. Now, this could be caused by a lack of intake or excessive loss, whether it's renal or non-renal, for example, gastrointestinal. And it's manifested by hypernatremia and hyperosmolarity. And you can see this set up by this nice chart here moving from angiotensin, the renin, it's really angiotensinogen, angiotensin 1, angiotensin 2, the effects as they follow through with ADH and aldosterone. And then, of course, we've got the mentioning of ANP, which is antagonistic to the entire angiotensin pathway. And so the effects are really opposite. Now, what we're going to do is look at regulation of potassium balance. Now, potassium is the most abundant cation in the body, and it is the main intracellular electrolyte inside the cell. So it's part of the ICF. 98% is sequestered within the cells. The balance of ECF versus ICF is regulated by the sodium-potassium ATPase pump. Serum potassium levels range from about 3.6 to 5.0 millimolars per liter. The condition for hypokalemia is when you have a serum levels below 3.6. This can be manifestations including generalized muscle weakness, paralytic ileus, where it's the area, the final area of the small intestine is not functioning. You can also have this occur as a result, you're going to get cardiac arrhythmias. What about the intake, distribution, and excretion of potassium? Well, intake is mostly by food. The minimum daily requirement is somewhere around 1,600 to 2,000 milligrams. That's roughly 40 to 50 millimolars or milliequivalents. Only a fraction is excreted through the digestive tract. Most of potassium is rapidly absorbed by the gut, and its excretion mostly would come out via the urine. Now, as I mentioned earlier, majority of potassium is excreted through the kidney. Filtered potassium is largely reabsorbed by proximal nephron segments, including the proximal convoluted tubules, the thick and thin loops of Henle. Now, excretion of potassium mostly is via the distal convoluted tubule and collecting ducts. Renal dysfunction will result in abnormal potassium levels. What I mean by renal dysfunction, if there's chronic kidney disease or kidney shutdown, you're going to see the potassium levels all over the place. Increased sodium reabsorption increases potassium secretion, and conversely, decreased sodium reabsorption decreases potassium secretion. Now, potassium will contribute to regulation of its balance by stimulating aldosterone secretion by the adrenal cortex. Activation of the RAAS system will stimulate aldosterone release. Aldosterone enhances renal and colonic, meaning in the colon, potassium secretion, promoting the loss of potassium in both the urine and in the stool. And we can see this when we talk about body mass, solutes, intercellular fluids, cellular fluids. But then what we've got is this nice little diagram here. When we talk about ECF, remember, plasma is considered part of the ECF as well as the basically the extracellular fluid outside of the cell. Inside of the cell, the main electrolyte, the main ion is potassium. The main ion outside is sodium right here. So what are the hormonal regulations of potassium balance? We've talked about them a little bit, but I want to give some clarity here. When we have aldosterone, that's going to be really the major regulator of the body stores of potassium, and mostly its effects are on the kidneys. It's going to increase synthesis and activity of sodium-potassium ATPase in the basolateral membrane of the distal tubule. It's going to promote cytosolic change of sodium for potassium and results in increases in sodium reabsorption and potassium excretion. When we talk about insulin, this is going to stimulate the entry of potassium into the cell. And this is by activation of sodium hydrogen antiporter which is resulting in sodium influx. You get increases in sodium that trigger the activation of the sodium-potassium ATPase pump, which will extrude sodium from the cells in exchange for potassium. Finally, we have catecholamines. And this is where we're going to go into just the beta-adrenergic receptor stimulation. This is going to increase cellular potassium by stimulating, again, sodium-potassium ATPase pump. And you can see this as a chart that relates both potassium and sodium. How you get aldosterone released from the adrenal cortex. The aldosterone will target the kidneys. As the potassium levels fall, the sodium is being reabsorbed by the kidneys. This will help normalize the blood levels of sodium and potassium. And you can see this when we talk about this being the lumen in the blood for salt retention without increased potassium excretion, potassium secretion without salt retention, and what hormones play a role here, both angiotensin and aldosterone. And it's important to keep these things in mind because, as you notice, this is distal convoluted tubule cells, and what is going to be changed as a result of these hormonal signals is going to allow for retention of sodium, but a loss of potassium. Or in some other cases, without the increased excretion. All right? Okay. Now, there's a nice chart I grabbed. I found this and I thought, well, this kind of summarizes things. Dietary potassium. A diet high in potassium increases potassium secretion. A diet low in potassium decreases potassium secretions. Aldosterone increases potassium secretion. Hyperaldosteronism will increase potassium secretion and cause hypokalemia. In other words, low serum potassium. Hypoaldosteronism will decrease the potassium secretion and cause hyperkalemia. Hyperkalemia is when you have very high levels of potassium in the blood, and this can be very disruptive as well. Now, if you look at this, you want to keep in mind that the secretion from the blood into the tubule lumen is a two-step process. You have the uptake of potassium from the blood across the basolateral membrane by sodium-potassium ATPase pump. You have also the diffusion of potassium from the cell into the tubular fluid. So that's the filtrate via the potassium channels. All right. And three major factors that control this rate of potassium secretion. Basically, you have the permeability of the apical membrane to potassium, the driving force for the movement of potassium across an apical membrane, and the activity of the sodium-potassium ATPase pump. Now, acid-base and osmolar regulation of potassium distribution. We want to keep in mind that changes in acid-base balance can affect intracellular potassium homeostasis. Now, this might be a reach where you're asking, well, why is this so important? When we have rapid changes in water, plasma osmolarity, the shift in the water from ICF to ECF leads to pulling potassium out of the cell into the serum. Now, sometimes the changes in the pH of the blood can affect this intracellular potassium homeostasis. Hypokalemia is when you have a situation where the serum level of potassium is below 3.6 millimolars per liter. Most often, this is going to result from potassium depletion via abnormal fluid loss. So what do we have for abnormal fluid loss? Vomiting, colonic diarrhea, profuse sweating, diuretic use, or nasogastric suction. In other words, when you're pulling the fluid out, what's going to be coming out also will be the potassium, and so the potassium leaves the internal part of the cell, goes into the plasma to try to stabilize this. It doesn't succeed as well. And that's where you get hypokalemia. And the patients that are present with hypokalemia will demonstrate muscle weakness and changes in their electrocardiogram. Okay, let's move into regulation of the calcium balance. Now, serum calcium is also tightly regulated, 8.8 to 10.3 milligrams per deciliter. Calcium accounts for about 1 to 2% of adult body weight, and the majority, though, of it is sequestered into bones and teeth. Now, calcium is critical for cell membrane electrical potential, signaling mechanisms, enzymatic activity, the coagulation cascade, neurotransmitter release, and intracellular communication. A lot. If we look at the intake, distribution, and excretion of calcium, I didn't spend a lot of time with the numbers because the intake values vary with age, sex, and reproductive age. There is a positive correlation that exists between protein intake and urinary calcium. The catabolism of dietary proteins generate ammonium ions and sulfates. Usually the sulfates are coming from sulfur-containing amino acids like cysteine. This is going to result in the acidification of the plasma. This decrease in pH is going to trigger bone resorption to supply buffers such as citrate and carbonate with the release of the calcium into the circulation. Now, regulation of calcium levels are basically controlled by 3 key hormones: parathyroid hormone, PTH, vitamin D, the active form, and calcitonin. So let's talk about them very briefly. We spent a whole section previously on this. PTH is going to activate 1-alpha hydroxylase, which is going to convert vitamin D to its active form. It will also stimulate renal reabsorption of calcium and also bone turnover. Vitamin D in active form is 1,2,5-OH2D. This increases dietary calcium absorption in the small intestine and increases osteoblast activity. Now, this is going to result in stimulation of osteoclast-mediated resorption. Okay, so it's a little bit of a roundabout way of doing it, but it works. Calcitonin counteracts these effects of PTH and vitamin D. It prevents hypercalcemia by directly inhibiting osteoclast activity, which results in reducing calcium mobilization and release from the skeleton. So, what do you have here? PTH is going to lead to increase in calcium reabsorption, also phosphate resorption. All right. PTH is going to lead to an increase in calcium reabsorption in the kidney, a decrease in phosphate reabsorption. You will also have the activation of 1-alpha hydroxylase, which is going to be able to synthesize and convert vitamin D into this most active form, the 1,2,5-OH. PTH resistance at the proximal tubule, that will lead to a decrease in vitamin D. It will also cause a decrease in intestinal calcium and PO4 phosphate reabsorption. What will happen also is that you're going to have a decrease in serum calcium, but an increase in serum phosphate. Okay. Now, briefly, we're going to touch upon phosphate now. The phosphate balance. Phosphate homeostasis is maintained by intestinal absorption, renal excretion, the balance of phosphate in and out of cells, as well as hormonal regulation. Remember that phosphate is used for a lot of different things, including just the basic framework for DNA. But when renal function is compromised, you have an impaired phosphate excretion via the kidney, and that's going to result in hyperphosphatemia and the stimulation of PTH release. So when chronic renal disease occurs, you've got imbalances that occur for both phosphate and potassium. When we talk about intake, distribution, and excretion, basically after intestinal absorption, most phosphates undergo urinary excretion. Phosphate excretion by the kidney is stimulated by PTH through the inhibition of the brush border membrane sodium phosphate cotransport activity. Phosphate reabsorption by the kidney is increased by vitamin D and insulin through stimulation of the brush border membrane sodium phosphate cotransport, as well as inhibition of the phosphaturic action of PTH. And you can see this here, where phosphate handling would occur. The major mechanism for preserving phosphate balance is really involving renal absorption. 90% of the filtered phosphorus is reabsorbed in that tubule. The ratio will vary from 70 to 100% to compensate for large swings in dietary intake. So you may have something that is much greater in the excretion, and it may be due to phosphate rich meal, but you can see about 15% is excreted. And then when we look here for daily phosphorus balance, you'll notice that you have a certain amount that's in the intracellular fluid. The extracellular fluid will have a certain amount. You have accretion, exchange, and reabsorption in the bone. You have your diet of about 1,500 milligrams. You will have absorption of about 1,100. You will have the passage of some of it out via the feces. Okay? Now we're going to move into one of the last areas, which is sort of an interesting one. The neuroendocrine regulation of the stress response. Everybody gets stress. It's probably even stressing just to listen to this course, etc. But here's the thing you need to keep in mind. There is the capability to deal with and adapt to changes that occur. But there's also the difference of that being a short-term stressor versus a long, continuous stressor. It is the long period of time stressor that can have serious physiological effects, and that's brought on by a variety of hormones, some of them developing resistance, some parts of the body developing resistance to those hormones. Okay? Let's say we have the chronic activation of the fight or flight mechanism. And this is to restore homeostasis, and it can result in excessive or inadequate responses, which have severe effects on various organ systems. Okay. So first off, we look at the inhibition of the reproductive function. Now, keep in mind, person's under lots and lots of stress, so what's going to happen? They're going to have cortisol. They're going to have the cortisol-releasing hormone. And you're going to have also ACTH as part of this. So we have enhanced release of CRH and beta endorphins, and that's going to suppress gonadotropin releasing hormone. It's going to affect LH, FSH. So all of those hormones are going to be suppressed, and it will produce gonadotropin resistance at the gonads. Next, the inhibition of IGF-1 axis. Remember that there's a relationship with growth hormone and then the insulin growth factor number 1. Both of them play a role in growth and development. But chronic activation of the HPA suppresses growth hormone release and thereby will inhibit IGF-1 effects at the target tissues. Then we have suppression of thyroid function. CRH and cortisol will suppress production of TSH and inhibit the activity of peripheral 5-deiodinase. This is going to result in euthyroid 6 syndrome. If you remember that, sort of like Well, they look okay, but they're having a high amount of T3, T4 because the deiodinase is not breaking down the present levels of T3, T4. So it builds up. Dysregulation of energy substrate metabolism. Increased catecholamines will stimulate lipolysis and decrease triglyceride synthesis in white adipose tissue. Remember, there's two different types. There's brown adipose tissue, which mostly is used for thermogenic means. White adipose tissue is really that which stores lipids and things like that. High cortisol levels resulting from HPA activation result in increased gluconeogenesis, produce insulin resistance, inhibit lipolytic action of GH, and inhibit bone remodeling by the sex steroids. Alterations of the immune response, which is the last one. There's a significant rise in cortisol levels that affect all aspects of the immune response. Glucocorticoids will exert anti-inflammatory effects. They will, as a result, increase the risk of infections. If basically you are suppressing the immune system, which is what long-term exposure of glucocorticoids does, then you have a problem where you become more susceptible to various types of infections. CRH may have a direct pro-inflammatory effect on the immune system as well. And you can see some of these in this diagram here of what the effects of stress can do on the body. And you can see that some of these are triggered in part by the hormones, cortisol, etc., cortisol here. And as a result, this is why some individuals under very stressful situations get very sick or have an increased risk of certain illnesses. Well, that runs us down to the case studies. Now, the case studies will be available each week. Basically, I will have those posted and expect them to be done by Friday, 4:59 p.m. Sidebar note, because this is coming up with Thanksgiving week, I will take care of things and the students will not have to be there because our normal case study time is on Thursday. Now, next week will be our last week. I'm going to view a few other hormones and other topics, endocrine disruptors and goitrogens. Have a nice day.